Good morning, everybody. Uh, I'll be talking about bacillary layer detachment, prevalence and clinical features in posterior uveitis. There's no financial disclosures. Bacillary layer detachment is a recently recognized OCT finding that describes a split within the inner segments of the photoreceptors, just posterior to the external limiting membrane. So, according to Mehta et al., there are two factors responsible to form Ballard. That is a hydrostatic force from the choroid, which has enough strength to split the photoreceptors, and a space in the zone of weakness of the photoreceptors in a segment myoid within the external limiting membrane and the ellipsoid zone. So retinal acute fluid accumulation is sudden and rapid influx of intraretinal and subretinal fluid. It is said to be more responsible for development of Ballard. Choroidal ischemia is another possible pathogenesis. It is associated with weak age sympathetic ophthalmia, which can also have Ballard. It responds well to steroid therapy. So the aim of this study is to determine the prevalence and clinical features of Ballard in patients of posterior uveitis and to determine its prognostic value. Material and methods was done among 25 patients of posterior uveitis presenting in the OPD at tertiary care center. Inclusion criteria included patients aged more than 18 years with the presence of BD on OCT. Exclusion criteria, patients who were not willing to give informed consents and who had a substantial media opacity. The results, 36 eyes of 25 patients with Ballard were included in the study. Mean age was 49. Mean BCVA was 1.03 according to the logMAR. Mean CMT was 745 micrometers. There was no correlation between the BCVA and the CMT. So this is the graph showing the age and gender distribution of patients of posterior uveitis, which shows that there was the highest was among the age group of 40 to 49 years, and the prevalence of Ballard was the highest in weak age. This is a table showing the prevalence of Ballard in various causes of posterior uveitis, which showed highest in weak age. And the line graph showing the change in the visual acuity of weak age in before and after treatment. So which shows that the patients of weak age without features of Ballard had a better improvement in the visual acuity after treatment. This is the table showing the differences in the average visual acuity at presentation of the patients of posterior uveitis. We show the presentation at presentation almost all the whether with or without Ballard had similar visual acuity. So this is a few of the pictures of our patients. Case of weak age, which is showing the features of Ballard. Case of prostate branch angiitis. This is recurrent multifocal choroiditis, also showing disorganization of inner retinal layers and features of Ballard. Case of tuberculous choroiditis, and also it is seen in a patient of SLE and choroidal osteoma, one patient. So there were different patients diagnosed with VKH, choroidal neovascularization, toxoplasmic retinochoroiditis, prostate branch angiitis, panuveitis, tuberculous serpentinoid choroiditis, and in 6 eyes, the Ballard was located at the macula, and in 2 eyes in the mid periphery. The splitting between the IS myoid and the IS ellipsoid was found in all cases. In 3 eyes, the Ballard was isolated. In 2 eyes, the internal splitting of OPL and outer nuclear layer was noticeable. The follow-up of 6.3 months was available in 7 eyes. Complete retinal flattening took about 14 days. Progressive improvement of the 4 external bands followed in this order: ELM, EZ, and then finally outer segment tips or RP junction. So our study shows results where 5 eyes of weak age with Ballard had visual improvement with resolution of Ballard at 6 months follow-up, and 6 eyes of weak age without Ballard had a better visual outcome with improvement of more than the one without with Ballard. So another retrospective study which was conducted suggested that the median visual acuity at presentation was worse and had longer resolution period of 12 months. Our study suggests that the presenting visual outcome is similar in both sets of eyes. So there are still debates about the real topographic correspondence between the cell histology and the structural OCT images. So the exact location of the splitting in Ballard remains speculative. The splitting might occur at the level of IS myoid within the ellipsoid zone or at the IS-OS junction. The limitation of our study was the need for the larger sample size, longer follow-up period to assess the resolution time for complete or partial macular restoration, and to assess the final visual outcome. To conclude, our study suggests that Ballard was observed in series of posterior uveitis like leakage, followed by other causes like toxoplasmic, retinochoroiditis, and tuberculous choroiditis. Presence of Ballard in leakage can be predictor or for a poor visual outcome in comparison to leakage with only SRF. So the diagnosis and differentiation of Ballard from other causes of retinal detachment and retinochisis is important for clinician to determine distinct etiology. Thank you.
Okay, how many days you have given steroids for these patients and which route?
For patients of leakage, we would give, based on their weight, we would start weekly tapering doses, sir, for 3 to 4 weeks.
What was the time of resolution of Ballard after you started steroid? The mean time of resolution?
Sir, around after starting of 3 to 4 weeks, they would start showing some improvement and.
Is there any new entity which was not documented previously in the literature? You find in some case of posterior uveitis for the first time.
No.
All cases were previously also reported as having the bacillary layer detachment.
No, ma'am. That we found out on OCT, like what different causes of posterior uveitis, whether they had Ballard or not, that we saw through the OCT imaging that we made. They were not previously diagnosed.
Okay.